Hi friends, in today's case we are discussing fibroid polyp. So a fibroid polyp is basically a small fibroid which is growing inside the endometrial cavity. So endometrial cavity is the cavity inside the uterus where usually the baby grows. So today the fibroid is occupying the endometrial cavity and it's called a fibroid polyp. So these fibroid polyps typically present with infertility, that is inability to have a child. Patient may also have painful cycles called dysmenorrhea, that is she complains of extreme pain when she is having her menses. Patient may also present with extreme high amount of menstrual bleeding, which is called menorrhagia. That means every time she has her periods she bleeds more than what is normal. So today's case we are going to show you a live surgery. It is a slightly edited video where we will be teaching you exactly how this particular surgery goes. In the background I am also keeping the surgical sounds on. That means you will be hearing my cautery also. You will be hearing my call out for the different intrauterine pressures that I would be wanting, and you can also to some extent hear my thoughts and also the anesthetist talking to me. Thank you. Do see the video till the end to understand everything. In case you are new to my channel, my name is Dr. Mayur Pai. I am a laparoscopic surgeon, hysteroscopic surgeon, and also I do a lot of infertility and IVF in Goa in India. Goa is a state in southern India. So we have clinics in Vasco, Panjim, Margao, and in Mapsa. In case you are new to my channel, do remember, in case you like the video, do subscribe to my channel and press the like button. Also, if there are any questions, you can mention in the comment section below. I'll try my best to get back to you. So hi friends, today's case is of a fibroid polyp, which is a typical fibroid which is growing inside the endometrial cavity. So why I am showing you the diagram today is it's a hysteroscopic surgery, means we will be putting a hysteroscope from inside the vagina through the transcervical canal into the uterus and doing the surgery. Usually I directly go ahead and show you the surgery, but what happens is in a case like this where the entire myoma will be occupying this entire cavity, most people tend to get disoriented. So over here I am telling you how I am going to go ahead in this particular case, so that with the prayer that you get disoriented a little less and see the entire surgery. So we enter through the cervix. We will be entering like this. First we end up doing a diagnostic scopy. In diagnostic scopy we put a small diameter hysteroscope. We see the entire cavity, see where the myoma is, what are the extents and the borders of it, and we have also now found out that it is coming from the top over here. So this is the fundal area. But when you are doing a hysteroscopy, this is actually the far end that you are seeing, the cranial end. So we don't call it like fundus as such, we say this is the far end because that is what you see on the screen in your orientation. Now just like in laparoscopy, in case you are a laparoscopic surgeon, you will know the most difficult to suture and operate the fibroids are on the posterior surface of the uterus. Now posterior fibroids which are close to the POD are the worst to operate. The same way in hysteroscopy, the most difficult to operate lesions are the lesions which are on this surface, that is on the far away surface or the actual fundal surface. Anything which is coming from any other wall of the uterus is very easy to operate. Also in this particular case you will find that the origin of today's fibroid is not just on the far away surface, it is on the far away ceiling of the uterus, that is the fundal anterior region, which is even worse. The reason being, whenever you use a resectoscope for the cutting of this fibroid, what happens is bubbles are generated. These bubbles, air goes high up when it's submerged in water. So these air bubbles will always go very close to this site or the base. Now two things happen. One thing is your vision gets distorted because you have to clean this area again and again, which you will see in this surgery. And the second thing that happens is a medical complication called air embolism, because all these vessels and everything will be coming from this particular area. When the vessels and all come from this particular area and you have cut them, there is a chance that these bubbles may go inside. Remember, saline going inside will just cause cardiac overload, which the anesthetist may compensate very easily, but all these embolism issues are something that sometimes only prayers cure. So this is the thing that we are going ahead with. Now as far as so after doing the diagnostic scopy, I'll be putting a resectoscope. We use a bipolar saline based electrosurgical unit. We use a saline based electrosurgical unit. So what we are doing is we are doing a bipolar resectoscopy using saline as the distension medium, which is considered way safer than using glycine. So over here I will be going and I'll be beginning my cuts over here. Reason why I begin, this is the right and this is the left. So this will be the left of the screen. This will be the right of the patient but left of the screen, whereas this is the left of the patient and the right of the screen that you will be seeing today. So don't get disoriented there. So over here, since I am a right-handed person, the way the resectoscope is, it is easier for me to cut this part first. If I were a left-handed person, definitely I will be doing this part first. Now this is exactly like how you people give what is called episiotomy, right mediolateral episiotomy or left mediolateral episiotomy. A person who is a right-handed will cut like this, whereas a left-handed person will cut like this, because that's what is easy to do. So I am a right-handed surgeon, so I find this very easy to do. So this is what my plan is to debulk most of it like this, and at the end reach this base. Once this base is well visualized, I would like to cut it right like this. So this is exactly how this surgery is. A part of the fibroid is also extending inside, very superficially inside the myometrium over here, which will be cut last. So this is the idea of today's surgery. I hope you will see till the end and enjoy it. Thank you. Here the surgery has already started. We have just entered inside with a resectoscope. Before doing this part, we have already done the diagnostic scopy, and on entry you can see that almost the entire cavity is full of fibroid. So here we are just giving our first initial cut. The initial cut gives you a complete idea whether what you are seeing is a fibroid, is a polyp or a fibroid polyp. So over here, only after the initial cut, remember the first initial cut will only penetrate the endometrium or the mucosa sort of capsule of the fibroid. So once you give a cut, you will be in a position to know exactly what is there inside. So here now you are seeing the entry through the cervical canal. The entire ball that you see is the fibroid polyp, which is causing the symptoms to this particular patient. So now that we have got a good orientation where the base and everything is, that we have seen through the diagnostic scopy part. It's a very good idea to do a diagnostic scopy, especially in these sort of cases, because since it's a small diameter scope, we can go very deep inside and even up to the base. Whereas if you try to use a resectoscope and try to see where the base is, you find it is a little difficult thing. Here the difficulties faced by the surgeon are that you can see that the entire thing is moving. It is just like you are trying to operate inside a bell, and the center part of the bell, you can see that it keeps on moving from side to side. It's not stable. So over here, one of the tricks that is used is that you energize the loop first and then you give a cut. Also, whenever you use a in this sort of a mobile where the pathology is very mobile, you have to see that the pull on the loop, the pull on the hot energized loop should be a little slow. Usually whenever it's a case where the fibroid is stuck very nicely and it's immobile, you can give very swift and brisk cuts. But over here you have to make sure that the loop is pulled out slowly. The reason for that is otherwise you have this sort of chunks where only the base is attached. So over here it's very difficult for you to get nice beautiful long strips, whereas there will be a lot of times when you are pulling this loop close to you and you find that the entire fibroid polyp is just getting pulled and there's not much cutting happening. You will find a lot of these strips happening today. Also you can see that at the ceiling end, that is the upper part of the screen, there is a lot of obscurity. This is caused by the bubbles that I was talking about earlier. You can see on top that mirror like thing, this is a bubble, this is a large bubble. So again and again we have to go up above the bubble and try to suck it out and flush it out. So the resectoscope has an inlet and an outlet. So what you have to do is you have to go at a high pressure, go into the bubble and let the outlet open. So that lets the bubble escape out. Some people use a suction also attached to the resectoscope, but I don't like that. So here as you can see, we have begun to cut the polyp. Again you can see that most of these strips, they are being cut, but at the very last moment they do not get detached from the main part of the fibroid. So sometimes you have to go to that small part and just energize for a little while, like here, to make sure that this strip just detaches from the fibroid polyp. The idea is, again, this chunk which is there is ideally thrown a little far away, but here the chunk does not go far away. The reason being there is no space there. So this is one thing. If at all you are a let us say if you are a urology surgeon, or in case you are a surgeon who is well versed with TURP surgeries, they always push the cut end far away into the bladder, whereas in this particular case we do not have the luxury to do that, because the further you go, more of this stuff is there. There is no bladder where you can push these chunks. So sooner or later these chunks always cause disturbance in the visualization. Usually another rule is there that whenever you do these sort of resectoscope surgeries, 2/3 of the loop should be ideally visible and only 1/3 of the loop should be digging in. Whereas in this particular case you can see so many times I can only feel the loop but I cannot see the loop. So this is a surgery where certain rules and principles of resectoscopy surgery cannot be fully followed. So this sort of a surgery you should only be attempting once you are very well versed with operative hysteroscopy. That means you must have done these cases a lot of times, so as to be able to understand where the loop is even when you are not seeing it. Like you can see over here, most of the loop I am not able to visualize, but before giving the cut I exactly know where this loop is, and I will definitely be knowing what are the consequences of this particular cut. Also you can see, now I am trying my best to make sure the strips which are cut are as long as possible. So over here what I am doing is I am starting very close to the fundus and I am trying to get the long strip out in 2 to 3 different pulls. So over here what you are supposed to do is put the resectoscope far inside, resector loop far inside. There you can see this is the base. On the screen you can see this is the base. Very often I just keep on going here and there to see how much of the base is left and just to visualize and get a feel of the anatomy. Again, these bubbles you can see, these need to be flushed out. See, this is the process where we are flushing out the bubbles. So you can see over here, this is the base. What the loop is touching, that's the base. So I go very close to the base and then energize the loop and bring it back. You can always see I waste around 1 second. Now again pull the resectoscope back, again pull. Now luckily this got detached. So over here you are seeing that the base is thinning out as we go ahead. Again go very close to the base and begin. Again go close to the base and begin. So ideally whenever possible we visualize very well and then go ahead. Now you can see these bubbles are a constant part of the surgery because a lot of resection is already done. So these bubbles are a little difficult and troublesome to deal with. So always go very close to the bubbles and flush them. Some of these bubbles come out or sometimes they get displaced and you have to continue with the surgery. So over here energize and pull. So there are two things that you are doing. One is you are making sure that the bases become thinner and thinner. Also the second thing that you are doing is making sure this fibroid is broken down into small chunks. Again go into the bubble and flush the bubble out. Okay, so here we were lucky, a lot of those bubbles were flushed out. So now again going and debulking the fibroid part of it. Yes, there you can see it. Here what I am doing is I am beginning as far as possible and coming lower down as close to the cervical canal as possible. So a long strip is created. To many this will be a very disorienting surgery, so I chose to first explain what I am going to do in the illustration, because to many people this must be a very disorienting surgery, and if that is so, don't worry, this is how the surgery is. However, the surgeon should not get disoriented and should be well versed. That's why at the same time we do take 2 or 3 cuts and go back and review the anatomy, how much is cut and how much is remaining. So that is the base from where most of the things are cut. Here what you see, this is the palpation that is going on. So we need to know exactly how much of the fibroid is there, and this loop also is an extension of the surgeon's fingers. So here palpation is going on before planning a cut. So now we are planning a cut. So there are times when you have to palpate just beyond and see how much of the fibroid is left. This palpation has to be done using the loop. You have to be able to feel the pathology using your instruments. Like many a times many surgeons or senior gynec surgeons keep saying, in laparoscopy you don't have a feel. The truth is you always have a feel. Only thing, the feel is not like the feel of the from the fingers, but an experienced lab surgeon or an experienced hysteroscopic surgeon can always feel the tissues. So the feel of a polyp and a feel of a fibroid polyp is different. This you will know only when you have done plenty of cases and you have to learn how to palpate through your instruments. Otherwise it becomes a tough affair, especially in cases like this where vision is a little bit obscure or vision is a little bit distorted. So here a lot of my vision is coming from the field. So here we are going on the near the left corner of the patient, that is the right of the screen, to see how much of this thing is remaining. Definitely I feel it, if I could very easily go and start doing this loop cutting from that side, it would be easy. But what happens is, for that I'll have to use my left hand. I would have to place my this loop in the left hand and go ahead, which I find a little technically difficult to do, especially in a case where accuracy is very important. Remember, though hysteroscopy sounds like easier than laparoscopy, hysteroscopy is more non-forgiving as compared to laparoscopy. The reason being, you are operating inside the endometrial cavity and you should try your best never to damage the endometrial cavity and cause an injury that will cause consequences like fertility issues. So now this is very close to the base. I have now I am planning to to detach the main fibroid from the base. So I'm calculating my further cuts. Again, I'm just palpating before I place the actual cut. Sometimes you see that I am placing mock cuts or practice cuts before doing the actual cutting part. I like to do all my cases with my personal teammates who are my staff. We are having an excellent OT brother, and we are having three excellent OT sisters who are making my life very easy, and that is not being recorded, but my one staff is all the time on transabdominal ultrasound, because actually I always use a transabdominal ultrasound during the case. This helps me in preventing perforations, and over a series of lot of cases I have found that that is a very good way to get oriented also. Here you are seeing that I have shifted on to the other side to just debulk that part of the base. Here clearing the air bubbles. Now this is you can see the angle of the hysteroscopy loop is different. That's because I am holding it in the left hand and trying to cut from left to right, means left side of the patient to right, and left side of the and right side of the screen to left. So sufficient amount of cuts have been made there, which makes it very easy for me now. So again shifted to my dominant hand, and now you can see that only a very thin amount of this tissue is there. So now instead of taking sleeves out long slices, I am just using it like a typical cautery and just cutting it, doing a digging inside, and then I go for a slice. This exposes more part of the. Now again cleaning. After almost every one or two slices, you can see there is a significant amount of bubbles which are generated. These are steam bubbles. You cannot avoid them because you are operating in water that is saline. So again we give few cuts and then pull to get a strip. Again flush it out.
Yes, sir.
Also during this flushing, before the bubbles sit back into their place, you have very good vision about the base. Look at this, you know exactly where the base is. So remember where the base is and then go ahead. Yes, now we know exactly where we are. We have visualized it very well. Give a few cuts. Very nice cut. That made sure that a lot of it got chopped off. You can see some of these cut ends are somewhat distorting the scopy. Again, try your best to make sure that you have as good vision as possible. So that is a very small part of the base that is remaining there, that is being palpated. That's the base. Some of these are pieces of fibroid, some of these are old pieces of old strips, but they are all there because there's a very small place to cut. Unlike urology surgeries, we do not have a bladder where we can park our strips, so we have to make do with what we have. Also, it's not a very, sometimes a person may feel that we should get these strips out and clear the passage, but that becomes difficult because to remove these strips out we use an ovum forceps, and that ovum forceps does not know whether you are holding the old strips or the fibroid which is still attached. So also when you keep on introducing the scope in and out, a lot of air embolism issues may occur. So it is always good to make sure that this is done in one sitting. Now you know exactly what you are seeing on the screen is just the base. So if you just chop this entire base, your job is done. But it is easier said than done because of the poor amount of vision that you are having and little bit non-cooperation by the tissues. Remember, these tissues are hangling and dangling, and they are not very taut, so it is not very easy to chop the base. That these tissues are not under tension, so it's not like laparoscopy where you hold the tissue in one hand, pull it, and then use the dissector to cut. Here you are making sure that these tissues are cut the way they are. Here a good amount of palpation is done. I am behind the base, and definitely I can just energize and pull, but I have to be very careful and make sure that normal endometrial tissue is not harmed in the process. So again, lot of these bubbles, flush them out. Flush them out. These bubbles, remember, are made of steam. This steam is because of the water which is turned to steam, the water from the saline distension medium. Here short bursts are done. Here again we are breaking another rule of resectoscopy, I would say. We do not usually push the loop, we always pull the loop, but sometimes it is difficult. Now you can see that we have made sure that this main fibroid is almost out and detached. There it is, detached. So now it is the time when you have to check for bleeding. This is when you can decrease your operating pressure and go ahead. Sometimes the question always remains of how much of distension pressure to use. The right answer for that is it depends on what you are seeing and visualizing in your laparoscopy. Till you have to have that lowest pressure in which you are having enough vision to operate. Here you are getting rid of, we are getting rid of the last few tags which are there. This is the base, this is the fundal endometrial area, more like fundal and little bit anterior wall. If at all it was more on the anterior wall, it would have been a very quick and easy surgery because of the way the angle of the resectoscope is. Here you can notice that the base is parallel to the loop. Whenever it is parallel to the loop, it becomes a little difficult to cut. If the pathology is directly perpendicular to the resectoscope, then it becomes very easy to cut. The easiest fibroids to operate, or easiest lesions per se to operate, is ones which are on the floor of the uterus. Here you see pressure is decreased, there is bleeding there. Go touch the area and do coagulation. So this resectoscope has the ability to use cutting current and coagulating current, just like a cautery pencil. Resectoscopy that I did just now is done with pure cutting current, and now I am using pure coag current. So I generally like to take only the first 4 or 5 large size bleeders that you get. Remember, this is a very magnified view, so amount of bleeding in ml is not so much, yet it is always a good idea to, now see, this one is flooding the area. So now increase the flow rate, increase the pressure, go and plug and coagulate that bleeder. So this is exactly how you achieve a little bit of hemostasis. I do not like to achieve a lot of hemostasis because that causes a little bit of scarring, I believe. It's always good to make sure this bleeding is sealed medically, that is by using things like methergine or oxytocin infusion, etc. This makes sure that there is very minimal amount of scarring and the endometrium grows back without any scarring, giving you excellent fertility at the end of the case. So now we have already finished removing all the pieces out with the ovum forceps, and this is the check scopy. Again, you cannot put a diagnostic scope in because the cervix is now very dilated. You have to put the larger scope that you have used in the particular case. You can see that the cervical canal is very roomy. This patient is also a case of PID. So you can notice that this one's ostium, the right ostium is very low down. That's because the uterus is actually twisted. It is not that I am holding the camera in a wrong position. but you can notice that the person's ostia is on the right ostia is very close to the floor, right there, okay, in the center of the screen, right there. That's the right ostium of the case, whereas the left ostium is somewhere inside the base of this particular fibroid, and it was not well visualized. Anyways, we'll be planning for a check hysteroscopy after 2 to 3 months, in case we are planning for any. Usually, I plan a check hysteroscopy in most of my cases who require an embryo transfer, but this is done roughly around 1 to 2 months before the actual embryo transfer. Now you can see that the feel of this thing is a little bit rigid. So this is fibroid tissue, so this you have to remove out. So always at the end of any particular case, you have to look for the look and the feel of the tissue. This is fibroid tissue, this has to go out. This again is fibroid tissue, this is little bit fibroid into the myometrium, this has to come out. You have to make sure that only muscle fibers remain in the myometrium, and there should be no fibroid tissue, because fibroid tissue is not going to respond very well to fertility and stuff like that. So we just want normal muscle tissue in the base.
And also I want your eyes here to prevent. She will detect once it happens. प्रेशर असं ते 150 कर.
Again, the reason for the minor bit of struggle over here is because the area which we are operating is directly perpendicular, and what you have to do is energize the tissue and move the resectoscope and not just pull the loop, which is not as easy as just firing and pulling the loop. Here you can see again the resectoscope has to move. So there are specialized loops which are available who have a slightly different angle, but then again, if you are good at it, you can move the resectoscope and achieve the same results. That's what I usually like to do. Very little amount of fibroid tissue which is there. Very little amount. That's it. It is almost out. I hope you enjoyed today's surgery. It was a little bit difficult, at least initially, but as it went by, it became more and more easy. I hope you did not get much disoriented in the case and you understood how we did the case. I hope I could explain what I did and what I was thinking during the different stages of the surgery, and I hope this will help you in your surgical practice. Thank you so much.